everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Conversa Health. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion, and we will get to them at the end. Stay tuned immediately following the discussion and join Christine Lee, who will lead us in an energizing midday stretch session. And with that, I'll throw it over to our moderator who joins us from Frost & Sullivan, Renita Das.
Good afternoon, good morning, good evening to all of us who have joined from different parts of the world. Thank you so much, Health, for taking the time to do such an important topic. My name is Renita, and I'm a partner and senior vice president at Frost & Sullivan. And I don't know about all of you, but I have done approximately 25 webinars with public audiences so far. And I do have to tell you that I'm getting really tired and lonely out here doing this. And it doesn't get easier. The feeling that you experience by doing something in person, the excitement of being on stage and making eye contact and seeing a live audience around you, it just charges up your senses and your brain. And I think it's so different to a virtual webinar where you can't see anyone. You're trying to gauge the temperature in the room, take a wellness check, respond to people, as well as all the issues with tech support as well. So I do hope COVID-19 will end very soon, and then we can go back to some new ways of doing things. So if I relate the same analogy to the whole aspect of virtual care and healthcare, which is what we're here today to talk about, I just think it's almost the same. If we look at the care in terms of healthcare, and we look at virtual, somehow it doesn't seem all right because this model relies on physical separation through a screen, through a text, through a call. And in my view, I feel sometimes virtual care is almost the antithesis of the essence of medicine. Doctors in their white coats were there to provide comfort, security, human touch, reassurance, hug, compassion, empathy, and now we're looking at physical separation through a screen. Yet, on the other hand, I believe it's the only model of care today that has saved millions of lives across the globe, and eventually it's digital tools like this that have kept us connected and well and able in a very safe way. Therefore, today, I think it's even more important for us to learn what this virtual care environment will look like, what it is, and how, when everything dies down, how we will use this as we come out of the crisis. And I have three fabulous great minds from the industry who are here with us to share their experiences and best practices of what virtual care is. They're practitioners on the field doing very, very important jobs in terms of saving lives, as well as implementing technology to make this possible. So I'd like to take a few minutes to have them introduce themselves. We have Murray, we have Nick, and we have Zena. So Murray, do you want to go ahead?
Sure, thank you, Renita, and thank you, Health, for having us today. I'm Murray Brzezinski. I'm the CEO of Conversa Health, and we are a team of caring, data-driven, passionate, proactive problem solvers. Those are our values. And our team wakes up every day and we build solutions that harness the wisdom of patients. And we take that wisdom, we bring the patient into their care for the purposes of improving access and improving health outcomes. So very, very focused, simple mission that we have. We have some wonderful people waking up every day doing this. We have wonderful partners. And I'm thrilled to be here with two of them today, Dr. Zena Brown from Northwell and Dr. Nick Patel at Prisma Health. So thank you.
Just quickly, we have a little polling question up there. It'll help us understand where you are from, which industries. So if you can quickly take it, then we will share the results as we move forward. Dr. Zena, do you want to go ahead and?
Sure, good afternoon, and thank you, Health, for inviting me to this important conference. I'm Dr. Zena Zenobia Brown. I am a Vice President of Population Health and Medical Director for Health Solutions at Northwell Health. Health Solutions is our care management and population health shop, which means that for Northwell Health, which is an integrated care delivery network of 23 hospitals, 80,000 employees, 6,000 physicians, et cetera, we help to implement and move forward with our value-based care strategies. So thank you for having me on the call today, and I've worked with lots of different technologies around making those population health strategies kind of come to life.
Population health, such an important topic, which we'll get to definitely. Dr. Nick, over to you.
Thank you, Renita, and great to be here with the health team. Dr. Nick Patel, I'm an internist, been practicing about 17 years, also serve as Chief Digital Officer and Vice Chair for Innovation for Department of Medicine. We concentrate on our digital continuum of healthcare products for digital health, delivering seamless care to our patients when and where they want to be seen, using digital health, both video and asynchronous means, as well as working with our teams in data and health, population health.
Wonderful. So I just want to start off actually by defining what we mean by virtual care and virtual health so that everyone's on the same page of what we're talking about. Virtual care is really a very broad term that encompasses a lot of ways healthcare providers can remotely interact with their patients. So in addition to treating patients via telemedicine, which is probably what you've heard a lot about, providers can use live video, audio, chat, instant messaging to communicate with their patients remotely on a daily basis if necessary. Virtual care involves many more components of digital care than just telemedicine or telehealth. For example, if you have a virtual visit with a doctor that could focus on an immediate problem that you're facing, an urgent care issue, or it could be as part of a chronic management disease program. A virtual visit is usually an evaluation of a patient that focuses on the issues that are raised by the patient or as a follow-up. A virtual care solution, on the other hand, involves a much wider area. It includes clinical work, it includes workflow processes, remote monitoring, and obviously using providers over time. So virtual care extends the options of managing the patient well beyond a specific event. So at Frost & Sullivan, where I work, we've done a lot of studies looking at how the virtual care market has been impacted as a result of COVID-19. And if you look around the media and just read what is going on, we're seeing growth rates of almost 67% of this market, growing to about 124%. Recently, I had a chance to look at claims data for the last 2 months for virtual visits and consultations, and we found that has grown by 600% in the US over the last two months. And we also found, doing a survey with consumers, that almost 40% of consumers in the US in the last 2 months have used some form of virtual care, which is almost really, really high numbers compared to where it used to be. So obviously the industry is going through exponential growth as a result of this pandemic. What I want to put out to our audience, to our panelists today, is really an important question that I think that we should be thinking about as participants in the industry and as stakeholders, is that once this crisis dies down, what are some of the things we should be thinking about and ensuring that we need to make sure it happens so that we continue with virtual care in some form as a standard of care, and it doesn't become one of these Wild West business models that are temporarily engaged during pandemic time. And I want to start this question by really focusing on the patient. What are some of the things we need to be thinking about from a patient perspective in terms of patient expectations, maybe navigation tools, engagement tools, to how to deal with this once life becomes normal. So I'd like to throw it open to the panel. Anyone wants to take this on?
Rena, it's Nick. I'll be happy to take that one. You know, my mantra is something that Steve Jobs said. He says it just works, and flexibility and ease of use is extremely important for the patient. It's something that drives me when we think about our additional tool set, is not to pick things that are complicated and disjointed, but to really have a connected experience, both from all the platform, but it's also a hybrid experience. It's not that we're going to exclusively see patients just virtually. But to your point earlier, you can also see patients in the office. For example, I'm actually seeing patients today right before this and after this webinar. And I have a few patients I'm going to see via video. Some I'm going to just call. And then I've got a whole bunch of patients I'm actually seeing in the practice today. And so you have to try to think about how does that mix work and how does it work seamlessly so the patient's not confused. And I think mobility is key. As you know, most patients, most people in general have cell phones. And so they're accustomed to using these mobile devices, and they're accustomed to using them with the ease of use in retail space. And I think that's one of the important parts of improving and continuing that patient buy-in and engagement long term.
Great. Dr. Zena?
I would 100% agree with all of those things. And I think as we're thinking of a go forward, it's really, as Dr. Patel said, it is not about one solution. It is about now truly seeing healthcare in a different way. And in many respects, the patients are much further ahead than the healthcare infrastructure to actually leverage those technologies. So I think that one of the things that as we're thinking about the patient experience, starting from a place of, what drove those thousands of additional telehealth visits were the patients, right? So we need to rebuild the future, understanding that the community, the population is at a level of complexity that is beyond the infrastructure that we have to meet that. So as we're building what in essence is a brand new patient experience infrastructure, we need to keep that in mind. And I think we'll kind of get into the dynamics around the provider and how the provider really becomes part of that, to your earlier point, Renita, which was, how do we keep the humanism in the healthcare, knowing that, to Dr. Patel's point, that doesn't mean the same thing for every patient. And for some patients, it is a much more accessible platform to be able to do this digitally than in person, which creates for some patients many barriers that are not traditionally considered as we have deployed healthcare historically.
Thank you. Definitely. We'll talk about infrastructure in a little bit. I want to hear what Murray has to say because he's actually implementing this with with the amazing work he's doing and some interesting stories he has to share. So go ahead, Murray.
Yeah, no, I agree with both Nick and Zena. We're working with both systems on this new patient experience platform that Dr. Zena Brown's talking about. So I think both of them highlighted our starting point, which is it has to start with the patient. You can't know what one patient needs and what another needs without asking the patient. And your statistic around the explosion of telehealth use, what's really happened during this time is the total number of visits have gone down substantially during COVID, but the percentage that have been shifted to telehealth has gone up substantially. So it's critically important and it's going to change the future of healthcare, but we're still talking about the episodic, necessary synchronous connection with a provider. And that's a piece of virtual health, as you said, but I think where Dr. Zena Brown and Nick Patel are going is when we come out of this, I think forward-thinking health systems are going to be thinking about virtual first. How can we reach out to every patient and understand where they are in their health and their care, and then use technologies to determine what is the right venue for that particular patient. Now, to do that, you need to collect information from the patient, this wisdom of the patient, and understand their personal situation in their journey. If they're trying to stay well, or if they're dealing with a chronic illness, or they're preparing for a procedure. And then the question becomes, can that patient, based on the way they want to interact with the system, do it in a fully automated way? Do they need to have a live chat with a physician? Do they need to have a phone call with a nurse? Do they need to have a telehealth visit? And in those instances where they want to have an in-person visit, or it's necessary to have an in-person consult, how do you have a sort of an end-to-end patient experience platform that understands the patient, incorporates that into the workflow of the system? And I think that's where COVID, to me, was a catalyst to move the industry in that direction.
Absolutely, absolutely. It's been a watershed for the industry because telehealth has been around for a long time, but we never got reimbursement or the healthcare systems were not able to take it seriously enough because of a number of reasons. So the big question that I have now to this is that obviously we're in a value-based system and we're looking at clinical outcomes, we're looking at cost savings. So as we go into the new normal, how do we think about measuring the value that is coming out of virtual care? Obviously, the population is one area to look at, which I know many of you are doing extremely interesting work. A care journey pathway could be another way. I just want to get some ideas from you of how you all are looking at outcomes, because that's eventually going to become the way forward if this is going to become the standard of care. So any one of you, please feel free to jump in.
So I can give sort of a quick example around that. I mean, I think, in the population health strategies are all around, outcomes, and as sort of hackneyed as it is, this idea of this triple aim. So when we're thinking about outcomes, it really is, what was the total cost of care, for the clinical outcomes around, especially we think about the high cost events like readmissions, like ED presentations, and then at the end of all that, what was the patient experience? And that is also an outcome in that it is part and parcel of future revenue, right? So none of it is helpful if the patient doesn't come back to your system. So in COVID in particular, there are many clinical examples, and I see in the Q&A a lot of questions about those examples. But in COVID in particular, we deployed because two things were important. One was that clinically there were certain things that we understood if we touched base with the patient very regularly, because COVID is a disease that changes rapidly over time. So the traditional model of like, oh, I'm just going to see the patient today and they are fine, does not apply, right? We know there's a decompensation day 5 through 8. So thinking about how are we going to clinically sort of manage that care, and two, lots and lots of patients. So, and I failed to say Northwell is a health system in New York City with several hospitals in Queens, so really the epicenter of the epicenter globally. So lots and lots of patients. So how do you bring these two things together? So one of the things we did was deploy a conversational chat for patients who were COVID positive coming out of our EDs and our hospitals, so that the chat could have a meaningful interaction with the patient for all of those days. That was backed up by people, but when you think of what you're going to need to scale that kind of clinical interaction, you quickly can see that, especially in a pandemic situation and for some of these diagnoses like heart failure, pneumonia, the ability to have a person do all of the touches that are necessary to get to the outcomes that you want, which are safe patients, patients who feel hyper-connected at a cost of care where you're avoiding deteriorations in clinical events like rehospitalization, like ED presentation. That is one example of how we have sort of deployed technology against this broader issue as it relates to COVID in particular.
Yeah, I agree with that. Renita, the whole healthcare system in general is changing more from a fee for service to value-based care. So a focus on quality is key. It's crazy to imagine that in healthcare we haven't even, we just started that journey recently in the last 5 years. And if you go to a store and you buy something and it's not exactly up to your expectations, you return it. But in healthcare, if you pay your bills and you go see a doctor and your outcome is poor and you don't have good control of your sugars or your blood pressure, there is no reimbursement. There is no anything that comes back to that patient. They still pay their dues. They still pay their co-pays. And so having skin in the game for healthcare systems, I think, is going to change things. And this is why I think that digital health is going to play a very important part, because those digital interactions that occur between visits, those 3 months, 6 months, 12-month visits, are going to be key to improving those outcomes. Staying in touch through a chatbot, staying in touch with a remote patient monitoring that monitors your sugars, your blood pressures, your exercise, your overall wellness are going to be those key touch points that are going to help with those outcomes.
Excellent. Nick, anything from your side?
Thank you, me, Murray. I'll jump in. So yeah, I agree with both what Nick and Zena said. I think building on Zena's point about the triple aim in thinking about outcomes, we also now think very equally about the quadruple aim. So adding the burden on providers, and burnout's a real issue, and we're going to have a shortage of 2.5 million providers over the next couple of years. And COVID showed sort of, kind of laid bare the capacity issues that we have in the health system. And then the other thing that COVID made clear was there's a lot of risk in going into a clinical venue. So if you can see my shirt here, we also added a fifth leg of the stool, which is helping people stay connected without getting infected. And it's both for the patient as well as for the provider. So when we think about outcomes, we think about those 5 areas of outcome, and it's all about outcomes. So it starts again with the patient experience. And, when I think about it from the platform that we've developed, if I piggyback on what Nick said and what Zena said, there's times where, a chat, an automated interaction is the lowest cost, highest frequency interaction you can have. What that allows you to do is get from the patient, how are they doing? So you can determine whether you need to have a higher cost intervention for the patient or not. So what it does is it allows real-time access to patients when they need to be intervened. So you're getting much earlier interventions, which really, sort of stem the complexity of the situation getting worse and being higher cost and being a worse outcome. And you automate the interactions and the care for those patients that don't need the higher cost, scarce resource. So you're allowing providers to practice at the top of their license. You're driving patients to telehealth visits when they're needed, in-person visits when they're needed, remote patient monitoring devices on the 5% of patients that need them. That 5% is not static. So how do you reach out to patients? And you're constantly risk stratifying where those patients need to go in the platform, the sort of hierarchy of care. And when we measure outcomes from a platform like this, we find that, for example, we've seen readmission reductions of 30-40%, all-cause readmissions in a Medicare population. We've seen 70% reduction in no-shows for procedures like colonoscopy, because it's not about just reminding a patient that they have a visit. That's not why patients don't show up. There's lots of reasons why patients don't show up. Some are nervous about the risks of the procedure. Some are worried about insurance paying for it. Some don't have access to transportation. The way to get that information is to talk to the patient and incorporate that in the workflow of the provider. So we're seeing adherence, really, really tough therapies. People go off their treatment plan because they're experiencing adverse events they don't report. We can reach out very frequently with these platforms and get them to report it and then respond. So it's really behavioral health sort of being embedded, behavioral science being embedded into technologies that can, on behalf of providers, reach out very frequently to patients.
Anyone else wants to comment? I want to spend a few minutes talking about the infrastructure part of it, because healthcare wasn't set up to be delivered virtually. Healthcare is not a consumer business. It's never been. But now we're bringing in a lot of the consumer technologies to manage people's health. We're talking about healthcare organizations tracking patients on a regular basis, not just when they have an episode, which is what sick care was all about. Obviously, the whole structure of healthcare and the infrastructure that's been set up is not catered to this disruptive change. So what are some of the things we should be thinking about as we move forward, not what's happening now in terms of the pandemic, but how do healthcare providers now think about integrating a lot of new things into their system, obviously starting with the electronic record and making that accessible through different platforms, through different providers as well, so that patients eventually have access to everything anywhere they go, taking the concept of care anywhere, anytime, any place.
Well, I think one of the things you have to realize early on is that we got to stop looking at them as just patients, but truly consumers and customers. My CEO, Mark Ahala, said something great in one of our meetings, and he goes, in healthcare, we don't make anything. We see patients, we take care of them, we do procedures, but we don't actually produce a car, we don't build a building. You know, it's nothing that we actually do like in the retail space. And so what we are in is in the people business. And in that people business is about improving patient experience, improving access, having those easy, frictionless access points throughout your system. One of the things that we have done is, you know, produce an app called Prisma Go that every patient gets to download and has access to their Epic MyChart portal, can have access to the digital health services throughout the system. All of those are extremely important. And it's, you know, we don't have to just concentrate on folks that have technology. We have to consider the fact that there's a lot of patients out there that don't have access to technology. They may have not the technology literacy that's needed to have these touch points. So having patients brought into the office and being able to educate them on these tools, and sometimes giving them those tools, giving them an iPad or a Google tablet or another wearable in the office and explaining them how to use it is very important. And I think data modeling and trying to figure out what is your at-risk population. You know, is it all your value-based care patients, and risk stratify, as Murray said, around, you know, uncontrolled diabetes, hypertension, COPD, CHF, you know, those high ER utilizers, those high readmission folks.
Nick, are you there?
And how do you?
Lost you.
I'm sorry?
We kind of lost you for a second.
Oh, okay. Can you guys hear me okay now?
Yes, yes.
Well, I was just saying this, the biggest thing is to make sure that you keep patients at home and give them the tools that empower them to take care of themselves in between office visits, to reduce those 30-day, 60-day readmissions and improve those outcomes. And I think that's why, you know, having patients come into the office, as well as enabling them with wearable technology and chatbots and things of that nature that make healthcare less burdensome, and also continuing that constant education is very, very important. And so I think using different type of technologies that you have in your tool belt, but making sure that you're integrated all that into your EHR as well as your data centers. You know, I think CRM is very important, you know, to be able to understand all the different entry points of a patient in the system, both from ambulatory side, the acute side, from getting a mammogram to all the other community work groups and health groups that might be out there, is to be able to engage that patient and know that whole digital journey that the patient is on. It's not just about, you know, every single encounter coming into an ambulatory visit or a single encounter in acute space. Is really looking at the true string of events that occur in a patient's journey.
Great. Dr. Zena, Murray, any thoughts on this?
Yeah, I mean, I think that was, you know, incredibly well said. You know, the only thing I would kind of add to that is that and I'll actually build on a question that's in chat, which was, you know, how do the patients want to be sort of connected to their providers? And Dr. Patel really kind of outlined this concept of sort of how do you connect with the patient across digital space in a way that feels connected to them. And I would sort of answer that question that came in online by adding, you know, that the patient is we have constructs in medicine, and one of the constructs is that people want to be connected to their provider. And what you sort of started off this question with, which is sort of just in general, how do people want to be connected, and what we know about engagement, to Dr. Patel's point, and how you get people into the environment, is that they're not always the most comfortable talking to the provider. They are not always the most comfortable going into the practice. So whether people choose to think about patients as patients or consumers or customers, you know, wherever you fall into that, in every category, it is about, in a meaningful way, meeting the need of that patient. And I think what, you know, Murray, I will just sort of underline the point that you made earlier, which is you need to hear from them to understand what that is. Because what we have done erroneously historically is cookie cutter every patient and said, okay, the way you're going to get healthcare is you're going to come in, you're going to sit for 15 minutes, or he'll sit for an hour waiting, then you'll sit for 15 minutes, and then I'm going to order a bunch of stuff, and then you'll go and do the stuff, and then you'll come back in a month, and like that's the pattern, right? And what I think we are challenged in health care to do, and what I hope we sort of embrace that challenge, is to say, yeah, no, that is totally gone, right? So, and getting enough information and data from the patients around what are the most effective healthcare interventions for you. And there is a lot of science around the N of 1 and how the thing that works for me is not necessarily the thing that works for someone else. And the only way we're going to know that is by getting information from the patient about how they are experiencing that care and what is the outcome for you in that care. So I do see a future where we really are, where the way healthcare is designed is distinct and it is different, and it is, you know, to Dr. Patel's point, like very kind of convening the data in a way that is important to the patient and in their driving their own healthcare and in our ability to connect with them in a way that is meaningful to them towards some of these outcomes, which sometimes is going to be not connecting them with a provider, but connecting them with a healthcare coach. If they're interested in nutrition this month, right, like it's January, that's what they're interested in January. That same patient in October is not interested in that thing, so connecting them with a nutritionist is not the thing. You know, in November, they're worried about breast cancer. So that if we can do this properly, we can create a system that is that flexible. And I think that's the other thing we haven't talked about, which is just the plasticity of doing things digitally as opposed to kind of the brick and mortar kind of vision of how healthcare happens, where it gets very hard to change how people do things.
Yeah, I think this is. I'm sorry, Renita.
Go ahead. No, go ahead, Mike. Go ahead.
I think this discussion right now, to me, is the heart of the issue to making the healthcare system of the future successful. So I'll start with what Dr. Brown said and work back to what Nick said and bring it right back, Renita, to your question about the EMR. So this notion of an N of 1, we think about this all the time. So I think healthcare historically has treated the average patient.
I didn't even know that, Murray. You think about that all the time?
Yeah, I wake up thinking of N of 1. That, yeah, I need to actually see a physician about that. But so this notion of treating the individual person rather than the average patient, right? That gets at two things. One is personalizing what that person needs, and it's treating the person as a whole person, not as a patient, which is Nick's point about thinking of them as consumers. It's not consumer versus patient. It's really thinking about them the way they think about themselves. We all wear different hats as we go through our days and our lives. And again, you can't understand where a patient is in their health journey or their care journey without talking to the patient. So if I bring that back to the EMR, EMRs weren't designed to capture data to treat patients. That's not why they were designed. They happen to have a lot of data that's super helpful in treating patients. It's predominantly clinical. And if you look at all the literature, you know, outcomes, we used to use clinical data to predict outcomes, and now we know that 10, 15, maybe 20% of an outcome is predictable or determined by clinical data. But you have to look at social determinants and behavioral data and genetics, and there's a whole bunch of other things that determine. And so if you could sit down and you're an empathetic provider like Dr. Brown and Dr. Patel, and you could sit down for hours with the patient every single day, you would get all that information and you would be able to help them guide the patient on their journey. You know, I hear people trying to develop technologies. We're the GPS of healthcare. We're going to take a care plan, digitize it, and tell you turn left, turn right. That's great if you think you know where the patient is going, but the patient knows where they're going. The patient has all this information about themselves. How do you bring that out and then sit down with them and help them achieve their health, wellness, and care goals? So the digital platform of the future, and I think what we're trying to develop, is how does it become an extension of what Dr. Brown and Dr. Patel would do if they could reach out to a patient every single day and ask all of these questions, collect all of this remote patient monitoring sensor information, combine that with the EMR data, and have a personalized conversation about where the patient is going. Based on new information, should we change where the patient's going? We talked about risk stratification. If you leave a hospital, you're a heart failure patient, you leave a hospital, there are enough studies to know, and predictive models are very powerful based on very few variables, 6 variables, some clinical, some social determinant. You can predict with 90% plus accuracy who's likely to be readmitted. But a day later, a week later, a month later, those variables change. You may no longer have a caregiver. You may have lost access to transportation, right? So once these things change, the risk profile changes. Now, it's very easy to keep that current if you could sit down and get an update from the patient. And so that's what this platform that we've built aspires to do. It incorporates chat, it incorporates asking questions and patient-reported outcomes. It incorporates anything you can capture from a sensor. It incorporates all of the EMR data, and it uses that to help the patients with self-care, help with shared decision-making, and that's what drives ultimately the outcomes we're talking about.
Renita, if I can add to what Murray and Dr. Brown said and some of the questions in the chat that I'm looking at is you also, healthcare systems really need to partner with the payers too. The payers need to be involved as best they can. A lot of these tools are expensive. Wearable technologies can be pricey. And and there's a question here outside of reimbursing for digital modalities of care. Do you see the payers, what are the payers' responsibility in virtual care? Well, a lot of it's sharing data, claims data, having seamless flow of information, both from the patient and the provider and the payer, so that you can have a true 360 of that patient. And also supporting some of the wearables. So if you, as a payer, know that you have a patient that is uncontrolled diabetic or has uncontrolled hypertension or has care gaps, being able to have tools in place that both the healthcare system and the payer share, and share that information and say, you know what, because your sugar's out of control, I'm going to send you a connected glucometer. I'm going to get you into a chatbot, and I'm going to be able to give you that information so you can stay connected to your care team. That's very powerful, and that doesn't happen right now. It's usually just one directional, right? It's unilateral. It's the healthcare system buys all these solutions, they buy wearables, and then they give them to patients. And they're doing that mostly to, again, improve outcome, and so that they, again, part of value-based care program, they don't lose dollars at the end of the day. But it needs to be more than that. It can't be just about saving dollars. It has to be for the greater good of the patient, and then everything else happens. And so payers have to partner with systems, and that goes to the community too. There's another question about, how about the communities? Those facilities can't afford these expensive tools. So are they going to lose those patients to larger facilities? Again, it's important to partner with your community. Prisma Health is the largest healthcare system in South Carolina, and 32,000 employees. It pretty much takes over 45% of the state, and 45% of patients around our area live within 15 minutes of our facility. So it's widespread, which means that you can't be everywhere at the same time, and that you have to partner with your rural communities as well as your payers, so that you can stay connected and give the patient the right tools so that they're not having to pay so much out of pocket to be in this digital journey.
So we had a polling question that we had put out. I'm not sure if any of you saw it or took it, but I think we have the results that I wanted to share that is out here. I believe the two top benefits of virtual health are, and it was a multiple choice question, and 69% of expand patient and physician access, which is pretty high, led by 44% talking about reducing cost and improving efficiency. So these are some results from the polling question that we just ran. I just want to quickly talk about moving from the patient to the provider side, because I think it's very important for us to think about how the business model has changed from where it started. I remember telehealth a couple of years ago. There were organizations that were created that had their whole list of doctors, American Well, one of them, and providers would contract with them to say, these are the doctors available, you can talk to them. But I think, and that was the outsourcing model that was built. But I think today it's a very different model that we are looking at. We're looking at a model which is very much insourcing. If I have a doctor and I have a good relationship with them, I would like to see my doctor. I don't want to go and see any doctor. And that's all about personalization that Dr. Zena and Dr. Nick were talking about. We're looking at personalization at every level. So can any of you just throw some light of what you think of this changing of the outsourcing to the insourcing business model, and whether it's here to stay or what the future will look like?
Yeah.
I can briefly talk to. Oh, sure. briefly speak to sort of Northwell's experience, and I think really the conversation about outsourcing came from a place of how would you possibly get a large workforce ready to go on telehealth in time for your strategy, your organizational strategy to use telehealth. And the answer was like, oh, that would be very unwieldy. Let's outsource this. I can say for Northwell, COVID solved that problem very quickly, which was lots of doctors with nothing to do but learn how to use telehealth visits. So we are doing that work internally and now have a workforce of people who are facile at using the technology and are starting to understand a little bit sort of how to leverage that in their practices. We've got a lot of different questions in chat, and just kind of combining a couple of them. I think your question, Renita, around, the physician perspective, and then some questions around kind of the infrastructure. So one of the things is, this is a skill, right? The ability to sit in front of a camera, look at somebody else digitally, and connect with them, right? We as humans, and clearly medical school has really evolved over the years in terms of the formal teaching of medical students. How do you connect with patients? How do you ask open-ended questions? How do you take their lead in something, right? So medical schools have not just sort of sat in the dark ages on that. They have really come forward. But now this is the next iteration of that, which is, how do you do all those things when you can't see the body language? How are you now, one, just how do you sit in front of the camera that gives the patient, that puts them at ease in terms of your ability to talk to them, the time you have to talk to them, can they, and I'm sort of struggling with light here because a rainstorm kind of came in, but can they see your face? Can they see your facial expressions? I think all of the, and then just the basic triage function, right? We are not taught in medical school this thing of like, you're just going to be talking to someone, you're not going to actually see their whole body, but how do you start to really listen, right? How do you listen as a provider to what they are saying? Because now that becomes critical in this way that over the years we have, as a profession, relied so heavily on, yes, just the questions we are interested in, but our stethoscope and the ultrasound and the radiology that we order and all these other things, as opposed to like, what is this person saying to me? So that is one piece of the infrastructure that really is I don't really hear a lot of people talking about that, but whether that's internal or external, the need to really train the workforce around a new skill set that is this. And then the other kind of piece of infrastructure that I did answer a question in the chat was really around the escalation and this idea of, patients are going to have needs that are outside of the physician's comfort level. And that is something we come into contact with a lot. And to your point exactly, patients want a relationship with somebody when it comes to their health care. They want somebody in their corner making sure all these things are going in the right direction. So really developing an infrastructure that can meet that need. So one of the things is, when patients escalate, does everybody in the organization know that there's access to these kind of digital resources, right? Does everybody know that if someone has escalated and said, hey, I was on this chat, or I was, digitally in this space, does that person who's finally answering the phone say, oh, there's a wealth of information out there about you, so before I say one word, I'm going to avail myself of that digital information, as opposed to our old way of doing things, which is I'm going to ask you the same 20 questions that you just got asked in some other way. So I think there are some infrastructure builds that have to happen, and just the only other one I'll mention is that escalation, which is after someone has given us the information, after we are in the telehealth visit in that moment and saying, you know what, based on this, you are having a PE right now. And that is a very real COVID example, right? We know all of these VTE events are happening. So now what is the infrastructure to get a truck to your house immediately? And how so it's like, no, I was on a telehealth visit, right? So if the EMS nurse answering my phone is like, what do you mean you're on a telehealth? It's like, I'm on a telehealth with my patient and they need this. So that infrastructure around what happens when an event is happening, the patient needs something, that's also going to be critical to, I think one of the questions was like the vision of healthcare of the future. Our ability to very efficiently and effectively and smoothly escalate care is going to be critical.
I think you bring up a very good point on holistic. I think eventually all of us want to be seen as holistically and not as a body part. And I think virtual health will make this tremendous transition to the holistic self in a way. Murray, Nick, any comments on this? It's a big question. It was a big question.
I thought that, I mean, I agree with everything Zena said. I'll start with your question about outsource and insource. I mean, if you think about how urgent care started, it was because there was a capacity constraint on the system, right? And telehealth is really the next generation of urgent care, and it was a solution to a problem. I couldn't get access to my primary care physician or the health system, and so I have this system outside the system, and now it's been absorbed in many cases into the system. If you're going to insource the provider network, though, which is what you're referring to, so you're using the technologies from telehealth companies, but using it with physicians in the health system to preserve the relationship, which I think is critical, then you're now back to having capacity constraints. And I think that's where virtual health in the broader sense can really help. So when I think about, for example, what we've done with Conversa, and it became very clear with COVID, all the telehealth companies were overwhelmed, right? They were underutilized. And then all of a sudden they went to 100% capacity and the need was, 1,000% capacity or more across the board. So the reality was most of those patients didn't need a telehealth visit, right? And so how do you provide a lower cost, more accessible way of helping those patients determine who should be screened out of going to a telehealth visit and identify those that actually do have a high probability of having the virus and get them into a telehealth visit or into a testing facility or into a in-person care setting. And so, for example, back to this plasticity, we were able with a virtual platform to work with all of our health system partners and develop very quickly a COVID screener and triage program that screened out 90% of patients who took it, identified the 10% that should be directed, and directed them to very local resources based on their zip codes. And that is an example in COVID, but I think that's the future. The whole idea is to take a trusted relationship and be able to scale it to a population of patients. And if you're going to be short, 2.5 million healthcare providers, nurses and doctors over the next couple of years, we already have an acute shortage. The only way to do that is develop technologies that the patient perceives is acting on behalf of their provider. So 24/7 check-ins, it's collecting the information, as Dr. Brown said. So when you do get escalated to a telehealth visit or an in-person visit, it comes with all the information. So when a patient is in one of our programs at Northwell or at Prisma, let's say it's a cancer patient. Now the cancer patient goes to see the oncologist. The oncologist knows all the information that the patient interacted with this chat and their EMR and all the connected devices they may be using. And so not only is it a more efficient visit, but it's a much more effective visit. And then the patient can go back in with that new information that got put into the EMR based on the consult. And so it's a virtuous circle. And as Nick said at the very beginning of this, these technologies aren't designed, if they're designed well, to replace. They're designed to augment. So that you can have personalized care, the connection with your provider, but you can do it at the scale of a nationwide health system.
Wonderful. Nick, do you want to add anything?
Yeah, as prior to the pandemic, driving provider engagement and buy-in was very hard because reimbursement for virtual visits was very restrictive. Providers' compensation was not aligned to digital health. And now that CMS and other payers have lifted most of those historic restrictions, everybody's on board. At Prisma Health, we've done over 170,000 virtual visits since March. It's unprecedented. All our providers adopted it very well and loved it. We got a lot of positive feedback from both patients and providers. And we're all working hard to lobby to continue to have those changes and reimbursement stay in place post-COVID, because I think it's very important. This has been a watershed moment for us to really see how important virtual health has been. And when you look at it overall, we thought we'd have a lot more people being seen by our outsourced providers that we had a partnership with, but most of the patients wanted to be seen by their established docs. And all those new patients that a lot of word well that Murray was talking about, it just wanted to know if they had COVID or not and just needed to have some reassurance, were kind of pushed towards a chatbot. I mean, in the first 4 weeks of having the chatbot up just for COVID screening, we had almost 38,000 people use it across the state. And we made it easy. So if you fall into a red box, you got tested. If you fall into a yellow box, meaning you have some COVID type symptoms, but you may have something else, you got a telehealth visit. And if you were just well, you got told that you were well. And so I think that a couple of things that we need to do from an infrastructure standpoint, though, that were challenges, at least for us, ramping up a 3 to 5 year digital health strategy that we had into 2 weeks, was making sure that all your hardware is up to spec, making sure that all your desktops are telehealth ready with cameras, mics, and speakers. I don't know if other people who have experienced this, but during these last 3 months, it's been very hard to find webcams and mics and speakers because everybody's doing what we're doing, virtual meetings and virtual visits. And we started to see our no-show rate jump from 4% to 40 to 50%. All elective surgeries were canceled. We knew that we couldn't just abandon patients. We wanted to make sure that we continued to stay in touch with them for refills and making sure they got their vaccinations. We set up drive-throughs for labs. We set up drive-throughs for lab testing, and all of that was done seamlessly using some of our digital tools. But what the biggest thing that you learn through that is how important alignment of not only technology and the need and your healthcare system is to be successful in deploying something like that. So that's key to providing that infrastructure to be successful in telehealth.
I just want to touch on another important point, if I may. We just have a few minutes left, and I thought this was an important issue. For many of you who have children, you probably know how difficult it is to do online education and online schooling. I have a daughter, so I know the challenges of doing that. But living in Silicon Valley, I got very involved in the community in the last few months, and we found that 20% of schools, kids don't have computers or laptops. So going to that, taking that same equation into the healthcare system, we have a large population, which is the most at-risk population today, that really need care, maybe using flip phones, maybe not having smartphones, maybe not having access to laptops. So how do we work through that? What are some of your experiences and stories of that? Because I think that's where the heart and soul of getting care to the right person at the right place at the right time becomes so critical for telehealth to be successful.
Yeah, I totally agree. In South Carolina, we're pretty, we have 5 million people in South Carolina. We're pretty widespread, spread out throughout the state. And so we're almost geographically distanced, which is good. And hence our numbers were lower. But what you find is, especially with schools and everything, that a lot of patients don't have access to broadband. And the only computer that they have is the computer their son or daughter have at home, given to them by their school. I was driving to work one day and I passed a school and I saw this gigantic line into the school and I didn't realize what that was for. And it's because most students still, the only meal they get in a day is the school lunch that they got 5 days a week. And those folks are going to school to get their lunches. And so we had this idea, it's like, well, if they're going to school to get their lunches, what would be nice is if we work with our school districts and tap into the Wi-Fi of the schools, which is usually very restrictive, as it should be, on the Chromebooks and other devices that students have, to allow telehealth visits. So we work with our school districts, so as the kids were in the parking lot, downloading their assignments, getting their lunch, where they could also do a telehealth visit if they needed to. And so that community outreach is extremely important and really comes to light all this social determinants of health that have come out during the COVID crisis. Access to broadband, access to technology, technology literacy. The list goes on and on to the things that we all typically think of as social determinants. And so I think it's very important to engage with your community and think about all those patients who don't have the tech, who don't have access, because those are important parts of your community as well as your patient pool.
What are you going to say?
Yeah, one of the things I just wanted to add was, I think we also have to be very careful about sort of narratives around underserved populations. Certainly there have been, in many of the same ways that we have historically had narratives around certain races and ethnicities, we want to make a new world where we're not dragging that into sort of the digital age. And, several surveys have looked at underserved populations or, using as a marker for that patients who go to like SQHCs, Medicaid populations. And it turns out that by and large, those folks have smartphones. So sort of this concept of like, well, this population is like, no, we can build it for the entire population of folks. But this secondary issue of there are people where, and a lot of that does fall, into certain age categories of people who are not as sort of technically savvy, much more so than I think sort of the socioeconomic piece. Having said that, one of the things we've done at Northwell is a trial, it's an MPT study, where basically you part of, again, back to infrastructure. What do you need in terms of people and resources in your infrastructure? And I love the example of the school and this idea of broadband. How are you getting people broadband? But where we had EMTs, right, who are off duty. So these are folks who are at a certain sort of price point who were going into the homes and setting up the, Wi-Fi enabled tablet with that older person to avail them of that visit. So I think that's just one example, but in every instance where there is a roadblock to technology, there are, really inventive ways to make sure that we can do this in a universal way. And as I said, I love the example of the school and how do you use the broadband that is there, because the school has broadband, the hospitals have broadband, there are broadband enabled devices. How do we, or asynchronous, so we talked about wearables, right? So, or even chats that are just, this chat's going to be asynchronous until you get to a place, until you get to, Target or Walmart where they're giving you free Wi-Fi. So, and doing private-public partnerships around those kinds of things. I just believe very passionately that all of these things are solvable, and to make sure that we don't go down this path of like, well, can't be done, like this is the socioeconomic status, can't we, this is for a certain group of folks. We want to make sure that we're not going down that path.
I would also add that, and Zena, you touched on it, I think these are solvable, and obviously from the perspective of somebody providing a solution, we're working with partners who are trying to provide broader access to technology, but there's a layer cake of access. So you can have access to technology, and to Zena's point, the narrative gets people off track because you still have to have cultural awareness, and you have to have sensitivity to different languages and cognitive ability and the ability to use the technology. And, so we think about that all the time. How do you meet, it comes back to personalization. Personalization isn't sort of some word in the sky. It really means how do you address a particular person's needs to drive better health outcomes? And it's extremely the variability is big. So how do you have an evidence-based platform, virtual platform, that reduces the variability of the care, but is enormously variable in how it addresses the person? And so, for example, we look at, I agree, in all of our studies, a lot more people in these communities than you would think have access to smartphones, but there are other devices that they might be using so we can meet patients where they are. If a patient has cognitive or physical disabilities that don't allow them to use the technology, how do you develop? We've developed caregiver modules that speak to the caregiver in the third person about the patient, recognizing that a caregiver might not have the same access to data that the patient does about themselves. So it's really thinking through how do you reduce all of the hurdles to access. And I think, broadband is certainly a big one, access to device is another one, but there's a whole layer cake on top of that needs to be addressed.
Thank you. I think we're getting close to the hour, so unfortunately we will have to cut off. It's been a pleasure. Thank you so much to our panelists. Big warm hand to them for coming on the line and talking about all their experiences and best practices. Thank you so much, Health, for putting this on the agenda, such an important topic. I do believe that virtual care, the impact of virtual care will create tremendous convenience and access to care. It'll create better patient outcomes and a much more efficient healthcare system along the way, and move towards a future where the patient is going to be, or the person is going to be, at the center of the ecosystem. So thank you so much, everyone, and all good wishes. Stay safe. Bye-bye.
Thank you, Renita, and to all of our panelists. If you'd like to continue the conversation, please join using the hashtag on the screen. And now I'd like to introduce Christine Lee, who will join us, or who will lead us in a midday energizing stretch. Thank you.
Hi, everyone. Hopefully I'm pinned. My name is Christine Lee. I've been a circus performer and instructor for the past 14 years, and since quarantine, I've been teaching virtual stretching. So I'm very excited to be here. I know that a lot of you have already been sitting at your computers and might be hunching over a lot. So this is intended to help you relax your neck and feel good today. So if you can, just stand up. It's only going to be 15 minutes and I will start to lead some stretches. So we're going to start first by moving your head side to side. And it's very important when you stretch to always start with more dynamic motions so you could get your body warm and ready for actual stretching. It's not good to ever just pop into the splits or go into a back bend. It's important to just get warm. So we're going to start with our neck side to side. And then we're going to look side to side. And if you have family members around you, feel free to grab them. This is a nice little pick me up for everyone. We're going to go head side to side and some circles. And I want to thank you guys again for having me here. It's important to integrate health and wellness into everything, especially as we're stuck at home. We want to make sure to stay healthy and stretched. So some neck circles. All right, let's move on to our shoulders. So some shoulder shrugs here, full rotations of your shoulders, waking up those rotator cuffs. And let's do some in the other direction. Same kind of circles, other direction, full shrugs, getting all woken up. And then from here, we're going to do little circles to the back, little arm circles. And we'll go in the other direction, little circles forward. And when you do these circles, try to really extend and reach your arms out long versus smushing them in, because we want full extension in our shoulders and those joints. Now we're going to do big circles all the way around. Big circles, full extension. And then the other way. And now we're going to start to open up our pecs. So you're going to bring your elbows back, chest open. This is a more dynamic motion. Don't go too crazy. We're still waking up. And now with our arms, we're going to outstretch them to the side. You're going to face your palms up, face your palms down, face your palms up, face your palms down. I know it looks a little bit like an 80s dance video, but you should get your shoulders waking up. And now we're going to warm up our rotator cuffs. So we're going to come up to what I like to call scared cactus and then a sad cactus. Get that full rotation. You might start to feel some heat in your shoulders, which is exactly where your rotator cuffs are. Alrighty, now let's start to roll out our wrists. I know a lot of you are typing a lot, so it's important to get your hands stretched out, your fingers stretched out. And if you're kind of going in one direction, try to also go in the opposite direction. And we could do some waves. These are a little harder to figure out, but I knew you could do it. And then the other direction. Okay, let's start moving our hips now. So we're going to go in big circles with our hips. And every time you go, try to go a little wider, farther range here. And then the other direction. When you do this, try your best to keep your legs straight. And again, big motions. Try to go wider and wider. And I'm going to turn down the screen a little bit so you can see my knees. We're going to turn our knees in circles from here. So hands on our hips, drawing circles with our knees. Big circles with our knees. It's important to do things like this before going for a super long run, making sure that your knees are warm, your ankles are warm, hamstrings are waking up. And then we're going to roll out our ankles. You should hear some cricks and cracks, and that's a-okay. It's liquid coming out into your joints. And then the other side. All right, from here we're going to do some knee circles. So we're going to get some rotation in our hip flexors. I'm going to turn the screen up just a little bit so my face is still here. And we're going to bring our knees into big circles out. Big circles. We're about halfway there, folks. This is just the warm up, and then we're going to start stretching a little more in the second half. Big circle. So try to draw the biggest circle with your knee all the way in, all the way out. You should feel your hips opening up. It should feel very nice, especially if you're sitting a lot or running a lot. And then let's go the opposite direction. So outside in. All right, okay, now our body is warm. We're ready to move, ready to stretch a little more. So we're gonna go a little deeper from, again, head to toe, just like we did, but a little deeper every time. So now we're gonna go with our neck to the side. And now you can put your hand on your head and do a slight pull. Don't yank it, right? Just a nice and easy pull. We're gonna relax here for a second. And then the other side, nice and easy pull. All right, let's switch it up. So same thing again to the side. Pull your head to the side, and now with your opposite shoulder, push your shoulder down to the ground and reach your hand to the opposite side. So kind of at a diagonal here. So really reach and pull all at the same time. You should feel lengthening in your neck here. And then we're going to switch. Hand on your head, pull, hand to the diagonal, push that shoulder down, reach that arm out, feel that lengthening in your neck. Now we're going to go a little deeper. So we're going to put our hand on our head, reach our shoulder down, our arm out, and now we're going to wake up our rotator cuffs and our neck and our trapezius muscles, which are back here, by doing small circles while we're pulling our head. And when you do this, really try to extend this arm out, right? We don't want to be smushing in. This ain't doing anything. We're reaching out and long. And you'll feel that lengthening in your traps and your neck. It should feel really nice. And then the other direction. All right, let's switch it up. Other side, pull that head all the way to the side and circles. And circles in the other direction. Okay, let's bring that arm across. This is a nice stretch for your deltoids. This is a good opportunity to do some wrist rolls while you're in there, and you'll feel it on your nerves all the way up into your shoulder. Should feel nice. And that's the arm that we're stretching, that we're rolling that wrist. And then we'll switch to the other side, pull it across, and roll out that wrist. And now one of my favorite, we're gonna grab our wrist and pull it all the way overhead and out to the side. And keep pulling that arm out, and now you're gonna feel it down your lats, down your QLs, and all the way down to your hips. So really extend here. And then the same thing on the other side. Grab that wrist, pull it overhead, push your hips in the opposite direction, and pull that arm. And again, you're gonna feel that extension in your lats, in your shoulders. Really good feeling here. Okay, now we're gonna focus on our forearms and our wrists for all the typers out there. So first thing we're gonna do is you're going to put out your hand, like you're asking for some money, but you're gonna then put your other hand on your hand and pull in. So from the side, it looks like this. You're gonna get a nice forearm stretch here. Maybe I'll just stand at a diagonal so it doesn't look so weird. And let's try other hand. Ask for that money, hand on your hand, and pull in. Getting our wrists nice and warm, getting our forearms woken up. And now we're gonna do the opposite. You're gonna show off your nails, and you're gonna put your hand on your hand and pull in, or your non-manicured quarantine nails. Make sure to keep your arms straight when you do this. And then the other hand, stick it out and hand on hand, pull in. All right, now that we've stretched out our forearms, we're gonna stretch out our fingers. So we're gonna do that same first angle with our hand forward. Now you're gonna grab your thumb and carefully pull it back, and you should feel a nice opening feeling in your thumb and your hand. And then we're gonna move on to the second finger. And then your middle finger. And then your ring finger. And then your pinky. Any favorite fingers there? Anything feel better than the rest? And then switch. Same thing, flip your hand over, grab that thumb and pull in to open up your hands. And then your index finger. And your middle finger. Oh, I got a little pop on my middle finger there. And my ring finger. And last, your pinky. Okay, shake it out. So now we're gonna do our last thing on our hips and our hamstrings. So we're just gonna lean over to one side. We lean to one side. And when you do this, try your best not to round your back like this. Try to keep your back flat. So your belly is the one that's being pulled down to your leg. And then we're gonna switch to the other side. And finally in the middle, here you could reach down for the ground or you can hold your elbows, but we're just gonna try to sink. Very important to keep your legs straight for this part of the stretch. Really good for your hamstrings, getting your abductors moving as well. And then from here, you can put your hands down for balance, or you can hold. We're gonna try to bend our knees slightly and strain. Bend our knees slightly and strain. We're gonna do one more hamstring stretch. We're gonna turn our hips to the side. So my feet are now facing the side of the room, and you can bend that back knee, and we're gonna hinge forward onto that leg. And then we're gonna switch to the other side, toes facing the other side of the room, hinge forward to that leg. Again, getting your hamstrings even more awake. All right, now you can kind of shake it all out, shake out your legs, shake out your wrists. Thank you all so much for having me. I hope you had a good stretch and I hope you have an amazing rest of your conference. Thank you again.
Thanks so much, Christine, and thanks everyone for joining us today. Have a great rest of your day.